Okay. Hi there, I'm Walter Wohlgemuth from Halle. I'm absolutely sure you don't know where Halle is and you don't want to know it. That's the reason why I show it to you. It's here. It's sort of in the northeastern part of Germany. And we will talk today about bleomycin electrosclerotherapy of vascular malformations. You all know that vascular malformations basically are divided into slow flow and fast flow malformations. These are some typical examples for venous malformations. They are soft lesions containing blood. If they are on the skin, they are bluish and they are not hot if you palpate them. They can be almost everywhere in the body. Here are some examples, like in the colon and in the hypopharynx and extremities everywhere. And you all know the lymphatic malformations, which are cyst-like things like sponges, and they contain not blood, but lymph fluid, as you can see in the left lower corner here. If you aspirate them, you get yellowish fluid, or sometimes there's a little bit blood admixed if they have bled in. And sometimes the microcystic lymphatic malformations, and they can be very troublesome, especially in treatment. They can ooze out lymph fluid through the skin. And what do we do if we have a slow flow malformation? We do sclerotherapy normally. And sclerotherapy is quite forward. You're puncturing the lesion, normally via ultrasound. You're injecting a little bit contrast to see whether you have an outflow draining vein, which you have to block. And if not, you can inject some sclerotherapeutic agent. It will be filled up with the agent, and this will cause a local inflammation. So things will get worse for the patient for 1, 2, 3 weeks maybe. And if the inflammation goes back, you have some sort of shrinkage of the lesion. This is nice. This is not, unfortunately, however, not extremely effective. And in most of the patients, you need to have at least 2, 3, sometimes more sessions. So the question is, how can we improve sclerotherapy? And the bleomycin electrosclerotherapy is something new, and we will see whether this will improve our results or not. Basically, the principle, the rationale behind electrosclerotherapy, or what the dermatologists call electrochemotherapy, they use this method since many years, is you puncture a lesion with electrodes, and then you inject, whether be it intralesional, or you can even inject a small dose intravenously, and via circulation, the bleomycin gets everywhere where you want to have it. And then you apply a current, an electrical current, a very short current, it's something like 100 microseconds. And by applying this current, which is quite a powerful current, the membranes, the cell membranes, for a short period of time, this is about 20 to 40 minutes, gets porous. And any agent which is extracellular can go intracellular now. And if the agent has its mode of action intracellularly, then it's much more effective. This doesn't work for all molecules. It works for large molecules like DNA. You do that for gene transfer, e.g. But it works for other agents as well. And bleomycin is one of these agents. And as you know, bleomycin is one of our standard sclerotherapy agents. And bleomycin is working basically intracellularly. So if you apply the electrical current, you can increase the intracellular concentration and by thus the effectivity. There are, even from the dermatological part in tumors, there are some cell experiments where the bleomycin concentration is measured and the cytotoxicity is measured. And if you apply bleomycin alone in a cell culture as compared to bleomycin and electroporation, the effectiveness increases dramatically. This is how it looks like if you do it. This is the applicator on the left side. And these are different electrodes you can use. All of them that are shown here are just for skin or lesions or superficial lesions like subcutaneous. If you puncture with the hexagonal electrodes, they can be moved out up to 4 centimeters. So you can go for a lesion which is a little bit deeper, but basically superficial. And the thing that makes it very interesting for us are the freely positionable needle electrodes. You can see the needle electrodes here. They do have an active part at the tip, which is from 1 to 4 centimeters long. And this is where you apply the electrical current. Ich bin gerade live auf dem Kongress. Ich rufe die später zurück. Sorry. And you basically puncture surrounding the lesion, and then you apply the current, and you get more effectivity out of your bleomycin. So how does it look practically from a practical point of view? You are, like in sclerotherapy, you're puncturing the lesion, made under ultrasound guidance. Then you inject the lesion. You want to know, is my needle really in the lesion, in the venous malformation, in the lymphatic malformation? You want to know by injection of the contrast media, is it like 2 cc's or is it 10 cc's or however, how big is your compartment that you want to fill up with your sclerosing agent? And you want to see, especially in venous malformation, whether you have a draining vein. If you have a big venous outflow, you will never be very effective because you have to block this outflow. Otherwise, the sclerosing agent will be gone and you will have no effect. And then you puncture the lesion with the needle electrodes. And then you have to be sure that your needle electrodes and your lesion are corresponding very good. So you have to control that. And to do that under ultrasound guidance alone is a little bit difficult, I can tell you from experience. So it's very helpful to make a fluoroscopy to see the contrasted lesion and the stick in needles, and you control it in 2 planes. Then you're sure that the active part of your needles is corresponding very good to your lesion. And if you have controlled them, you inject the bleomycin intralesional, and you're not injecting like in conventional sclerotherapy, you're using 1 milligram per milliliter. Here you can go down, because you increase the effectivity by far, you can go down to 25% of the concentration, like 0.25 milligrams per milliliter. And then you start the applicator, and the applicator applies the electrical pulses. So that sounds easy, but of course it's not that easy. When I started with it, I did almost everything wrong, and I want to spare you that. So I'll show you a couple of lessons learned. One is, here's a practical photograph during a BEST session. You can see the white needle electrodes here and the puncture needles here, and yet you can see 3 puncture needles. So you have to be sure that you cover the complete lesion, every compartment of the venous or the lymphatic malformation in your session. So you have to puncture a lot to really cover the whole lesion. The second is, how do you keep your needle electrodes parallel? What I do, I fixate them in sort of a triangle. I call that the needle trio. And there are some spacer elements applied, and you can keep them 3 centimeters apart, and then I stick them in in parallel, and that makes life a lot easier. And what is important is something that you see here. It's these X-ray images are done during an electroporation session, in this case with the hexagonal electrodes. And you can see the venous malformation here. It's in the distal part of the thigh. Here you can see the femur. And you can see the contrast admixed to the bleomycin. And if you puncture, you apply pressure. And it's like if you apply pressure on the tissue, you're compressing it and you're pumping out the bleomycin. So you don't have to do it like I did it in this case. You have to do it exactly in the reverse position. So you start the application and the pressure with the hexagonal electrode, you start it proximal and you next puncture is a little bit more distal, next puncture is a little bit more distal. Then you avoid the outpressing of the bleomycin. And you have to be aware, even if you reduce the bleomycin dose to 25%, it's the effect is more pronounced than in conventional bleomycin electrosclerotherapy. You can see a photograph here. You see a little bit swelling and a little bit of reddish skin discoloration. This is immediately after BEST, so you have a little bit more effect, inflammatory effect than you would expect in a conventional sclerotherapy. I'm often asked whether, if you puncture a lot into these lesions, whether it bleeds profusely or not. Interestingly, there's something like a vascular lock effect. So if you apply the current, you get immediately a vasoconstriction. And you can see this in this image here on the left-hand side. This is an arteriovenous malformation with skin infiltration, notoriously difficult to treat. And this is immediately afterwards. You can see all the punctures here from the electrosclerotherapy, and the image immediately below corresponds to an infrared thermography. And as you can see, so more whitish hue is warm, and you can see after BEST, immediately the tissue gets colder, and the AVM, the perfusion of the AVM goes down dramatically. So what are limitations? Well, there are limitations, of course. One is, and I already mentioned that as compared to a conventional sclerotherapy, BEST is a little bit more invasive. So you need to puncture, you are applying electricity, and you get a more pronounced inflammatory effect afterwards. We don't know exactly until now. There is not much evidence out there, but the effectivity remains to be evaluated, especially in prospective trials and in multi-center trials. We have performed until now a little bit more than 80 patients in Halle. Most of them were lymphatic malformations and venous malformations, and it seems to be effective in this kind of malformation. About AVMs, I don't want to talk at the moment. And of course, safety issues remain to be evaluated. There's no long-term follow-up until now. What are the local side effects? Seem to be mild to moderate, but the systemic effects remain to be evaluated. What's the evidence until now? If you look into the literature, there's more or less one paper out, and this came out recently. This is in venous malformation patients, 17 patients, and these were therapy refractory patients which had at least four or more previous invasive treatments like surgery or sclerotherapy without real effect. The mean cumulative bleomycin dose was 3 milligrams. And as measured in MRI, we had a 86% reduced volume of the venous malformations. So normally if you compare an MRI before sclerotherapy and afterwards, you don't see much change. Maybe the patient does better, he has less pain or whatever, but the volume is not decreasing a lot. So in best, and this was a little bit, most of the patients just had one best, the shrinkage of the lesion volume was dramatical, and even the clinical results are very, very encouraging. So 8 were asymptomatic without residual symptoms, and 9 showed good improvement as compared to 4.2 previous invasive treatments. So I'm showing you 2 difficult cases. One is a large facial venous malformation, and one is a skin microcystic lymphatic malformation with a lot of lymphorrhea. This is the kid with an extensive venous malformation. You can see it on the cheek, you can see it on the lip here. And the kid couldn't occlude the mouth. It was always drooling. And you can see a little bit here on the cheek, there's a black lesion. It was pre-treated with pure ethanol, and it had a fistula containing here and a necrosis. So this was a very difficult case. This is during the bleomycin electrosclerotherapy. I did this with the finger electrodes. You can see here the contrast admixed to the bleomycin and the finger electrodes. You puncture the lesion with the electrodes. This is the image after the first bleomycin electrosclerotherapy, and I did a second one. This is the image after the second bleomycin electrosclerotherapy. Mouth occlusion was possible without any problems. The lesion down there was healing, and you can see even the facial nerve was totally unaffected here. And the second case I want to show you is this large microcystic. It's a lymphangioma circumscriptum, and the patient had every day at least half a liter of lymphorrhea with a little bit of lymph to get admixed with blood. And this was a very, very difficult situation. You know that from conventional sclerotherapy, it's very difficult to treat. You can see a scar here from previous surgical attempts. This is again the finger electrodes here, because on the superficial skin lesions, the finger electrode is quite effective. And you can see the result here 3 months later, that there was a massive shrinkage of the microcystic lymphatic malformation. And there was, starting 6 weeks after the intervention, the lymphorrhea completely stopped. So if I have to summarize briefly our preliminary experience, technically it's feasible. There are some lessons learned, a couple of them I showed you. If you're interested in it, we are doing performing workshops at Halle with real patient treatments. The applied bleomycin dose is quite low. If you add electroporation, reversible electroporation, you can dramatically reduce the bleomycin dose, which seems a good effect to me. As far as we know today, it seems to be safe, at least compared to standard bleosclerotherapy, and it seems to be quite effective, especially in slow flow malformations. And we do have a prospective study in recruitment phase. Now we recruited 21 patients until now. So thanks for your attention.
Thank you, Professor Wohlgemuth, for that. That was excellent and very interesting indeed. We do have just a few questions from the audience, which is, the first one is, are there still possible issues with BIP, or are these reduced with best BST?
EIP, I don't know. What do you...
BIP.
What is BIP?
I'm only going to assume that this might be, is it intravascular bleomycin? Because some AVM are treated with intravascular technique compared to...
Okay. So there are issues with bleomycin and lung toxicity. This is especially important if you apply it intravenously. There's a cumulative maximum dose you can apply, and this is up to, it starts to be a little bit depending on the renal function in an adult, starting with 400 milligrams cumulative dose. And what we did in the paper published, and now we are, the mean cumulative bleomycin dose is between 3 and 5 milligrams. So we are sort of absolute. It's 100th. So we've never seen any systemic bleomycin-induced pneumonitis. That's what the question was. No, not.
Oh yeah, we did have the edition which is bleomycin-induced bloodvitis. Bloodvitis? Yeah, sorry, I can say that right. Yeah. And the second question is, we are, I think, we're hoping to set up this treatment for our vascular malformations service in Leeds. What are your top tips for doing this?
Oh, well, a vascular malformation treatment is something that's two things are very important there. One is it's absolutely interdisciplinary. You need a lot of different specialists interested in this topic. You need a pediatrician, you need a hemostasiologist, you need some surgeons, you need very dedicated radiologists, be it diagnostic or interventional. So basically, all the centers that I know that work are depending on the people doing the work. So you need to build up a network. And if you start, if you're interdisciplinary and if you're dedicated, patients will come from everywhere, because that's the same in Germany as is in the UK or wherever. So there aren't enough centers. So you never have to worry about getting patients. You have to worry about getting enough dedicated people. So I would start building a network, and all the rest is easy. And connect the networks together, and then you will be successful.
Thank you. It looks like that is a really useful tips for us. And hopefully when we can travel again, you can come and visit us, and hopefully my colleague, Dr. Karen Flood, would have set it up by then.
Thank you.
Yeah, thank you so much again, Professor Wohlgemuth. It's an honor to have you. Thank you. Thank you for giving us your time. Yeah.
Bye-bye.
Thank you. Bye.